The healthcare crunch that built month over month throughout the pandemic reached new levels this summer as emergency rooms closed and access to care seemed more precarious than ever. In response, the Ontario government just passed the More Beds, Better Care Act, that, among other measures, enables hospitals to move people to long term care if appropriate or bill them for staying if they refuse to go. Will it work? Is that fair? For their views, we're joined in Kingston, Ontario, Dr. David Pecora, President and CEO of Kingston Health Sciences Centre, Dr. Samir Sinha, Director of Geriatrics at Mount Sinai and the University Health Network Hospitals and Associate Professor of Medicine at the University of Toronto, and Jane Meadus, Staff Lawyer at the Advocacy Centre for the Elderly. Welcome to you for joining us in studio. Thank you so much, David, for joining us on the line. Dr. Sinha, I'm going to come to you first. Do you consider Bill 7 to be an effective solution to addressing Ontario's hospitals' bed crisis?
I honestly don't think it's an effective solution. I think it's certainly something that's been put out there as an idea. But the fundamental thing that we forgot to mention about Bill 7 is that it fundamentally takes away the rights of people to choose where they want to live. It's something about saying create more beds and provide better care. But when we're actually talking about people who have to choose where they're going to live, for example, we've always enshrined that fundamental right. And right now, we don't really have much in the way of empty beds in our system. And now saying to people that, look, we know you've chosen up to 5 beds. We know that you don't want to go to this other home, but we're going to put you there. We're going to shove you there, and we have the right to do that without your consent, if you will, to choose and get you placed in that bed. This is the fundamental issue that I have a problem with this bill, because it's actually attacking the rights of older adults, some of our most vulnerable people in our province, in order to try and solve a solution when there are bigger things that we could be doing and tackling to not have gotten into the situation and to, frankly, get us out of the situation.
Very good. David, I want to get your take on it. What are your thoughts when we talk about Bill 7 freeing up more beds in hospitals?
Well, there's no one solution to this. And, I look at the availability of long-term care beds in our region. It's a limited access point. Nobody likes to see beds sitting empty when we've got patients waiting in hallways and patients waiting to get in for acute care. And so I think, this is not a new issue. We've been having conversations with patients and families for many years. I'm an orthopedic surgeon. I've been doing this for a long, long time. And, no two patients or families are the same. And we really, try to find individualized solutions that work best for patients and family. And there are always challenges. There's always complexities, and no two issues are the same. And trying to find ways to nudge patients and families to think seriously about moving into a long-term care facility that may well provide a better care and scenario for them than sitting in an acute care bed, I think it's an important conversation to have with patients and families.
All right, Jane, I'm going to bring you in from a legal point of view. What are some potential problems with the logistics of sending elderly to long-term care facilities with Bill 7?
Right. So first of all, we're, just as Samir said, it's the fundamental right of someone to consent is being just overridden here. We're also looking at a system that's broken. We have a lot of issues. And again, we're taking seniors and using them to fix the problem. We saw this at the beginning of COVID. We shoved everybody out of the hospitals into long-term care. That didn't work very well, and we're doing it again. Every time there's a problem, we use seniors. We are allowing the home and community care services to send out information, your private personal health information, to anyone, any long-term care home they want without your consent. Those documents have a lot of information about you, very private information about you, about behaviors, about different kinds of medical issues that you've had, to go anywhere without your consent. And in fact, it may in fact be explicitly against your consent. You may absolutely say, I do not want this to go, and yet we're going to make that go. The act itself is very wishy-washy on a lot of its what it's talking about. So it talks about people having to make reasonable efforts. It talks about It doesn't tell us like how many kilometers away, what is going to be the parameters. We haven't seen the regulations yet. There's a lot of really questionable things in there. It seems to be allowing physicians and nurse practitioners and nurses in hospitals to determine eligibility. And what you have to understand right now is that hospitals, in fact, don't have a place in our long-term care placement system. They complete application forms. There are discharge planners who talk to you, but it's really the home and community care services that do that. And so they're supposed to be neutral, and now you have people whose prime objective is to get you out of the hospital. And we've been fighting that I've been at ACE for 27 years, and I've been doing that fight for 27 years.
I want to get David in on that to respond to some of what Jane had said there.
So I think there are some very real practical rights issues. We deal with that all the time. And that's why our intent, our practice has always been to try to manage challenges like this with a conversation, trying to tailor solutions to the needs of the family. We don't send people long distances away. It's more a question of trying to match what patients wish in terms of their preferred homes, and hopefully they will stay to preferred home. Not all want to, versus homes that they don't want to go to. But we do know that an acute care bed is not the right place either, and there are a lot of patients waiting to come in who need access to that. So it's there are. I recognize the rights of seniors for sure. We all have had elderly patients who've gone through this. I did certainly, and it wasn't easy and it wasn't fun. But on the hospital side, I can give you some scenarios of patients with real significant challenges waiting to come into hospital for cardiac surgery. I've had family members call me about a relative that they see declining week over week, waiting for cardiac surgery that's been canceled 3 times because of beds. And these patients invariably have other medical complexities, and their deconditioning and their fitness for surgery is at risk. And it creates a lot of anxiety for the patient, for the family, and for our team here. We want to get these people in and care for them. We've got patients with otherwise healthy, active patients with arthritis who are caregivers themselves, and they need to have their hip or knee replaced in order to be able to have an active life and look after their role in their family. And then every day I go down to our emergency department and see patients literally piled up in the hallway there with their family members in a far from our ideal circumstance. So, there are challenges everywhere in the system, and long-term care for sure. There's a lot of work that needs to be done. And, I think hospitals want to be part of finding those solutions. And we certainly have implemented some alternate paths to compensate for the limitations in home and community care and long-term care, which I can tell you about if you're interested.
Samir, I want to come to you. You've also had some very tough conversations with some of your patients in terms of what Bill 7 might mean to them. Do you mind sharing some of those conversations as well?
Yeah, I think the fundamental issue here is that a lot of patients are being stuck in a situation where we're now pitting sectors against each other. I agree, we need more beds in hospital, and we actually need more freed up beds, but part of the problem is we're losing nurses on the regular, not only from our hospitals, but also from our long-term care homes, from our home care system as well. We had 4,000 people when this government took power in 2018 on the home care waiting list. We have 16,000 people now. So more people are waiting in our hospitals as ALC patients right now because they can't get home care to return to their own homes. They can't get rehabilitation care. They can't get palliative. They can't get hospice care. Yet we're targeting this small group of people who often have made choices, said, I'm willing to go to one of these 5 long-term care homes, but I also appreciate there's 39,000 people on the wait list right now for one of the 79,000 beds. So now, as we say, yes, all of these conversations, people don't go onto a list without conversations happening that protect their rights. But now what we're saying is, well, frankly, if I can say this, it's a shit show right now. And you know what? We got people waiting in the ER who need this bed. There's a bed over in that home that lost 50 people during the pandemic that the military were involved in. I know nobody wants to go there, but you know what? They told us in a private conversation not involving you, they can take care of you. Let's go and wait and see. And don't worry, you can wait there for your preferred option, one of the homes you're willing to live in. That's the conversations. So we're talking about conversations that are allowed to happen now. And really what this act creates is structural coercion. Because now I can go to a patient saying, I know you don't want to go to one of those homes, but I found a home that you can go to. If you say no, I now have the power to charge you. One hospital has set up to $1,800 a day if you say no to going to that option. And most of these patients don't have money to buy private home care. They may not have family members who can take care of them and bring them home. So these are incredibly vulnerable people. And that's why when I was talking to one of my patients the other day saying, they were saying like, I'm not sure if we ever want to go back to the hospital because we realize this is a place where if I go and I end up needing long-term care, they might not respect my choices anymore. They might have the power now to force me into a home I don't want to go to. And when I said, that's what could happen, they said, well, then I'd rather die. And honestly, this is the conversations that we're allowing ourselves to happen by saying, we don't respect your rights right now because someone else needs a bed, because our government has frankly allowed a system to collapse further when there are structural things that we could have done to not allow us to start pitting sectors against each other and frankly stripping the rights of older people and saying, who's next? We're taking away the rights of mom and dad now to make choices in hospital. Next, we might make the choices and say, as an orthopedic patient comes in, having trouble getting consent, whether or not let's just go ahead and do the surgery, because frankly, the longer we wait to get them into the OR, that's gumming up a bed. What are the next rights that we're going to strip to deal with this situation we're in?
All right, I want to get to some boards and some stats here. Data suggests that 40% of the ALC, alternate level of care patients, are waiting for a space in long-term care. But in an opinion piece that you co-written for the Globe and Mail, you shared something slightly different. You wrote, the majority of patients waiting in hospital who no longer need to be there are not actually waiting for LTC beds. A significant portion of these alternate level of care patients are waiting beds in a rehabilitation unit, palliative care unit, hospice, or for care home. Before I get to you on that, I do want to get David in there to get in on a point that Samir had made there, but also on what he said in that piece as well.
So this afternoon, we have 18% of our beds occupied with patients who've been designated ALC, and half of them are, half of that 18%, so 9%, are waiting for a long-term care bed, and the other 50% are waiting for the sorts of services that Dr. Sinha said, home and community care, rehab, other types of care out there. So that's us this afternoon.
So, Mayor, I want to get back to you in terms of that quote and sort of the numbers. Can you sort of explain that a little bit in terms of the breakdown there? You're talking that majority of them are not actually indeed waiting for long-term care.
Yeah, and this really speaks to the whole system issues, right? It's not just our hospitals, and it's not people just like, Dr. Pecora, who's having trouble managing kind of his services, right? Without that. Hospitals are meant to be providing, hospital services. But when you don't have enough home care, when you don't have enough rehabilitation care, when you don't have enough long-term care services, this creates the crunch that we're in that then starts pitting each other because, frankly, hospitals have to provide care. And I don't know any person waiting for long-term care in hospital who's saying, I just want to stay here. They want to go to a long-term care home, but they want to go to a home of their choosing. The fundamental problems we have right now is that when you actually don't resource the system well enough, you don't actually have, for example, enough home care, the conversations I have on a daily basis with my patients and family is I say to them, right, so right now there's 15,000 people on the home care wait list. We can't really offer you much in the way of home care. I had one family being offered a few hours a week, and this is someone who needs 24/7 supports. The family's like, could you give us 2 hours a day? Like, they're negotiating. And when we say we can't do that, then they say, well, I guess we have to wait here for long-term care. That's not what the families want. That's not what the hospital wants, but that's what our current system is placing us all in these intractable situations. If we had a lot more home care, Kai tells us if we had more home care, about 10 to 30% of the people in our long-term care homes currently wouldn't even need to be there. If we had more home care, hospitals would be able to discharge more people home and wouldn't need them to wait there. And this is the problem. We don't have a right-sized system. And if you go to countries like Denmark where they adequately provide home care, they actually don't have an ALC crisis. In fact, when I talked to their leadership about what we have here, they said, why are you holding people hostage in your hospital? Why don't you just provide them more home care? That's what we do. We provide up on average 6 to 7 hours a day for people who need it. And by doing that, they have their own homes, they have their own beds. Why would you be so mean to your people? And I'm like, because we're systematically defunding other parts of our system to meet the needs of an aging population. So that's why we're having conversations like this, where we're debating whether or not people's rights should matter around where they might spend the rest of their lives.
Jane, I'm going to get you in on this. The long-term care minister stated that it's up to the patients and families to decide whether they want to be moved. Critics, like yourself, say that patients are ultimately being coerced into it. Some of that.
So yeah, and I just wanted to mention that, not only would home care allow people to go home, it would also prevent people from coming into the hospital to begin with. So if they had proper care, they wouldn't be coming into the hospital. And I think we really always are putting out fires instead of preventing the fires from starting. We also have cut down on all our chronic care facilities. The hospitals have closed the entire units. And so people with very high levels of care, who are the ones who get stuck in hospital, because really long-term care can't take care of them, they're being pushed into long-term care. And so that's a big problem. So with respect to sort of what's been going on, so as I said, I've been doing this a long time. I would say for the last 10 years, the issue of ALC has been the top issue in our office. We get between 500 to 700 cases a year on ALC. So this is not a new issue. Hospitals are trying to push people out. We have hospitals preventing people from applying for long-term care because then they can't throw them out of the hospital if they're waiting for long-term care. We already have hospitals who threaten people and say, if you don't do what we say, which could be go to a retirement home, go home, go to your daughter's house. We have hospitals regularly telling us, if you don't do those things, we're going to charge you $1,800 a day. That's not legal, but they do it all the time. Once this legislation's in place, we have the legislation, we yet to have the regulations. So it's not, as of today, actually implemented, although we have already seen hospitals basically pretending it is. Once it's been implemented, you are going to get a legal offer, and then if you refuse because they can't physically take you and put you into a car or an ambulance, because that would be an assault and a detention and all sorts of things, they are going to say, you have now refused a offer, and we are going to charge you the uninsured rate. So you are no longer entitled to your hospital stay by OHIP. We can't throw you out because it's not safe, so they're going to have to stay there, and they're going to charge you the uninsured rate.
Should I jump in there? I have this right, that Premier Ford said that his government would not charge patients that uninsured rate. Even so, I think I have the quote, I can pretty well guarantee it's not going to be $1,800.
$1,799.
$1,799, all right.
Well, I've certainly seen $1,800, okay? I've seen more than that, actually. Basically, what they usually do is they use whatever the rate is for the interprovincial rate, which is what a province will charge another province if one of their people ends up in one of our hospitals. So that's usually around the rate. They're not really tied to that. The Minister of Long-Term Care has consistently said this is legislation that's been around since 1979. It's only $62 a day. Unfortunately, he's not talking about the same thing. When you're an ALC patient and waiting for a long-term care home, the hospital is by right entitled to charge you the same basic rate that you would pay in a long-term care home. That is not what we're talking about. We're talking about, so that happens every day. It happens in your hospital, I'm sure to everybody you have, I'm sure it happens in your hospital. So every patient who's made ALC, except for a few exceptions, are charged this with a rate reduction if they're poor. This is, we're not going to allow you to be insured at all. So you're not entitled to any insured services through our hospital, and we are now going to charge you $1,800 a day. Will every hospital do that? No. Premier Ford doesn't have a say in it. That's not up to Premier Ford. It's not in the legislation, so unless he passes a law that says it's not allowed, the hospitals are entitled to do that, and they're going to do that. And there's memos from the ministry that say they're entitled to do that.
David, I have to come to you for a response on that one. A lot to unpack there, so.
We do charge some patients $62 a day, the copay that's equivalent to room and board. We haven't charged $1,800 or anything close to that, and have no intention of doing that. I think it's a difficult situation, and I understand the comments that are being made. Really, there's a lot of system solutions that need to be found. This is what Ontario health teams are meant to be all about. improving care in the community so that from a hospital's perspective, the upstream and downstream care is a lot better. Patients only need to come to hospital when they absolutely need to be there, and they can be discharged to the right setting when it's time for them to go. And we need to have a better integrated system. And that means even more integration with home and community care, and certainly more integration with long-term care, because that's been a missing element in our system so far. And hospitals want to be part of that because we are part of the system. As I mentioned earlier, we here, our experience with long-term care has been better. I think throughout the early phases of the pandemic, Kieran Moore was our medical officer of health, and they were very proactive with long-term care homes. And I think the success rate that they had mitigating the sort of damage we saw elsewhere was really excellent and highly publicized. So, these homes can step up when they get the right supports, they have the right standards, they're consistently inspected, et cetera. And they need to have the right funding. And Ontario Health teams are going to be part of the solution for the future. I think it's going to take time to get there. In the meantime, we're working with Ontario Health and Home and Community Care on a couple of programs. One of them is called a transitional care unit, where we have a contract with a retirement home that has empty beds, lots of empty beds. And so we provide the co-pays through that contract and enhanced restorative care to create this transitional care unit for patients who need some rehab services. Now even some patients who are likely going to be designated for long-term care and are waiting. And we also have a KHSC at-home program with enhanced home care services through an at-home program with a private provider. When home and community care support services doesn't have the staffing or the capability or even the capacity to manage some of those patients, and we work with home and community care in partnership, that program has been incredibly successful. Frankly, it's kept our surgical program alive. Last fiscal year, it saved us about 40,000 beds, we estimate. The patient satisfaction rates and quality indicators are really very, very good. And so we need to look at new models of care for the future. We can't just keep repeating the past.
All right, I'm going to get to a quote. This is a quote from another David Walker, professor of emergency medicine and policy studies at Queen's University. He writes, "I tend to identify with those poor souls who are designated ALC, for whom an acute care hospital bed is not a good or the right place to be deteriorating daily, for whom a nearby second or third choice LTC bed would be far better than where they find themselves. Of course, more and better home care, transitional care units, and more LTC flex would help a lot." Samir, I want to get your response on that. How do you sum that up?
I completely agree. The key is we're not talking about whether it's your first choice, your second, or fifth choice. You are allowed currently, under our legislation, under our regulations, to choose up to 5 homes. What we're talking about is if at Dr. Pecora's hospital, another hospital, what this legislation now says, if we don't like your 5 homes and we don't want to put in the extra effort and our dollars, frankly, to find alternative solutions, what we now can do is have a conversation with the home that nobody wants to send their loved one to. We can use your health information, we can get you accepted, and now, instead of working in your 5 choices and finding these alternative programs, we can simply say, look, we don't like your 5 choices because you're going to be waiting here 2 or 3 weeks, a month. We found this home up to 300 kilometers away, or in Southern Ontario, up to 100 kilometers away. And you know what? They've got a bed. And if you say no to that offer, we have the legal right now, through this legislation, to charge you up to, maybe not $1,800 a day, but name your figure, and it's going to be higher than $62 a day. That's really what we're talking about. I'm not saying that we should be holding people hostage in hospitals. We need to have the right types of care in our system that we need. But right now, we had a good system, or key investments that I fought for, called the high intensity for support services for older people. It was extra investments for home care, more home care, so people could leave hospital and go wait in their own homes. But instead, what happened at the end of this last fiscal year? Cut. right? Now, I've just heard that they're going to be renewing it after I've been protesting for more home care dollars. So they're going to renew it. So we're going to start and stop instead of building a strong home care system that gives people alternatives. Instead, we're now just passing legislation that's saying, we don't care about your second or third, fourth or fifth choice. We are now going to go beyond your choices and find you a home that you didn't want to go into, but frankly will take you, because if they don't reach their 97% occupancy, they don't get their full funding from the ministry. And right now, as of October 1st, what people aren't talking about is the ministry has also said for homes that can't reach that 97% occupancy, there's a reason why they're having trouble reaching that 97, because people don't want to go there. You know what? We now have a way to coerce people into those beds. So you know what? Your shareholders can get paid handsomely. These people won't necessarily get to be in the care they want. And sorry if your family can't easily visit you because it wasn't one of your preferred choices, but hopefully you won't die soon enough so you can get to one of your preferred choices. This is honestly why I find this bill so egregious and why I've been protesting so much. It's not about creating problems in the system. It's about focusing on the right solutions as opposed to saying that it comes at the cost of people's rights.
Jane, I'm going to come with you. You know, the last word, the last minute here. You know, if you do not support this legislation,
Yes.
do you think there is an alternative way for hospitals and LTC facilities to work together?
I think there are ways that they can work together. I think one of the things is with Ontario Health Teams, long-term care is often not even part of that conversation. They're not part of the Ontario Health Teams. It is in some places, but not everywhere. And so that remains to be seen. I think that people need to have the conversations. There are other ways if people think that substitute decision makers are picking up inappropriate homes, like only homes with a 10-year waiting list. There are other measures that can be done. My big concern is that we're taking people who are very heavy care, who can't get out of the hospital, and are going to be putting them into places that can't care for them, the ones that Samir was just describing. I'm also concerned about these transitional units because they're actually not part of retirement homes. They may be housed in them and they don't have any oversight. I'm very concerned about those units as well. And I think we really have to stop saying it's a seniors problem. It's a systems problem. And this, frankly, isn't going to fix it, because what's the real problem here is we don't have enough nurses.
All right, I guess we're going to have to leave it there. Jane, Samir, David, I want to really thank you for taking the time and really appreciate you guys joining us on the program.
Thanks for having us.
Thank you.
Take care. Pleasure.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.